All right, guys, we're going to go ahead and get started. Thank you again for joining us tonight. Once again, I'm Stephen Despins. I'm one of the co-chairs of the research committee, and I was going to be joined by my partner, Lana, who's also on the committee with us, but unfortunately there's some technical difficulties. So I'm going to try and lead us off tonight on my own, and we'll kind of go from there. As we all know, we're here tonight to start another journal club session, and for those that have access to the screen right now, as an AOCPMR member, if you're looking on the screen right now, is the main website, and as student members, residents, if you go to the students section, hover down to the journal club tab, you actually have access to all the journal clubs since the beginning of time. And tonight we're going to actually be discussing the most recent article, which is the February article, the Return to Primary Acute Care Service Among Patients with Multiple Myeloma on Acute Inpatient Rehabilitation Unit. So on my screen right now is the abstract. It was kind of an interesting article. For those that did not read it, pretty much this month's topic was cancer rehabilitation. So Lana, who unfortunately is not going to be able to join us tonight, actually chose the article. And what the researchers were trying to determine were factors that are uncontrolled that might bring a patient back to the acute care setting. Because remember, as a physiatrist, when a patient goes to, acute rehab, they have to have all their other medical conditions under control, whether it's blood pressure, diabetes, any chronic issues, any amputations, whatever. They have to be stable before they're actually a candidate for rehab. So if a patient ends up developing like a fever or an infection, they actually have to go back in to the acute setting, back to the actual hospital. And so what the researchers were trying to determine in this article was these other unbeknown factors. So this was a retrospective study. They went ahead and looked at patients that were admitted to the National Cancer Institute Comprehension Cancer Center between the years of March 1st, 2004 and February 28th, 2015. And they ended up finding 143 participants. However, after exclusion criteria, which included, if the patient was actually going to the acute setting for chemotherapy, they had some other reason that they were actually going to have to go back to the hospital, they were excluded from the study, and ultimately they ended up with 122 patients that they looked back on. And after looking at many different criteria, they determined that actually male gender and thrombocytopenia were the two most likely kind of factors that caused the patient to return to the acute setting. Although those were the two that were determined to be statistically significant, other factors that they looked at included demographics, characteristics of multiple myeloma, if patients were taking certain medications, certain lab values, and certain hospital admission characteristics. Now, for those of you, a quick review of actual multiple myeloma for the younger med students that might be listening, and for residents too, maybe it's a quick review, and for physicians that are actually listening, multiple myeloma is characterized, and I quote from Up to Date, is characterized by the neoplastic proliferation of plasma cells producing a monoclonal immunoglobulin. The plasma cells proliferate in the bone marrow and often result in extensive skeletal destruction with osteolytic lesions, osteopenia, and/or pathological fractures. And that was from Up to Date. And I'm sure from everyone's board studying and whatnot, very common characteristics that you look for when describing multiple myeloma is the mnemonic CRAB. So if everyone remembers what CRAB stands for, the C is for hypercalcemia, R is for renal failure, A is for anemia, and B is for bone pain. So if you have any of those type of criteria, especially in a 65-year-old or older gentleman, older patient, usually that should be kind of in your differential when listening. So overall, the study, I think, was pretty good. I know there were a couple issues that the researchers did determine that they wish they could go back and show, which included the four limitations included that it only focused at one specific institution instead of, on a global scale. They only worked, at that one research center that I mentioned. The second time was that, we're in PM&R, and one of our main tools at our disposal is the functional independence measure. And if you look on my screen right now, for those that don't know, this is the FIM, or the functional instrument tool. And ultimately, this is a tool as physiatrists that we use all the time, and it grades a patient's functional level on many different scales, specifically, activities of daily living, toileting, grooming, bathing, dressing, bladder management, bowel management, wheelchair, using the shower, using the stairs, and ultimately the patient on all those different categories is scaled from a number from 1 to 7, 7 being completely independent to a 1 being total assist. And this is really important in the rehab setting, because when physiatrists have their team meeting with the rest of the rehab team, PT, OT, nursing staff, RT, the social workers, all these members are telling the physiatrist exactly what the patient's FIM score is, and it's our job to determine if the patient's making progress or not. So unfortunately, in this study, one of the limitations was that they actually didn't use this as a criteria, which I think was a bit of a bummer, but that's definitely one of the discussion questions, which we'll get to, kind of alludes to that, and we definitely can incorporate it into future studies as well. A third issue that the researchers talked about that they did not include in this study was they didn't really look at comorbidities. So when a patient came in, they didn't really check to see, if they had a history of hypertension, didn't have a history of this, have a history of that. They literally only looked to see if they had been diagnosed with multiple myeloma and whether they came back or not. And a final kind of issue that they didn't look at was that, the indicators of multiple myeloma, such as hypercalcemia, again, the Ben-Jones proteins, M protein, the presence of plasmacytes, or even what stage the actual patient was in their form of cancer, whether they were stage 1, stage 2, or stage 3. I'll get specifically, as we get to the discussion questions, the actual staging that is used for multiple myeloma, but needless to say, for these patients, they did not actually separate them based off stage, which again, once we get to the discussion questions, I'll kind of go back to that and discuss that. I was kind of surprised that, there wasn't specifically, a certain group that I wish they looked at specifically. They really only looked at gender as a whole, male gender or female gender. It would have been interesting to see how, different ethnicities compared. Unfortunately, with the small sample size, I think that was kind of an issue. But overall, I think it was a pretty good study. And I think pretty much what we can take away from it is that, us as the physiatrists, it's kind of our goal to maximize function. And, these patients that come to see us are going to be on chemotherapy. They're going to be recovering from many different issues. And, although it's not our job to specifically cure the disease, because at this time there's not really a cure for multiple myeloma, but it's our role, to maximize function for the patient, because these patients are going to be debilitated. They're not going to be able to walk. they might not be able to stand, they might not be able to eat, they might not be able to, use the restroom, in order to empty their bladder or to, pass stool, which could lead to ultimate infection. So for us, it's critical, especially for these patients with multiple myeloma, as alluded to from this study, that the two main issues were, that caused patients to go back to the acute care were thrombocytopenia and, male patients. So, for residents that are listening right now, or actual just physicians or even medical students, this is critical that, if you have a patient on your service and, they happen to be diagnosed with multiple myeloma and they happen to be a male, they're more likely, according to at least this journal article, are more susceptible to be returning to the actual hospital versus their female counterpart. And obviously, as we know with thrombocytopenia, it's the disorder of low platelets. So what does that mean? That makes the person susceptible to bleeding, which can increase their chances for hemorrhage or, a hemorrhagic stroke or any type of bleed anywhere in the body. Again, because they've eliminated any kind of common reasons to go back into the hospital, such as chemotherapy and stuff. Those factors most likely were not reasons that these patients returned to the hospital, because that's what they did not look at. I'm kind of skeptical to think that even when these patients did have to return to the hospital for these specific reasons, such as male gender and thrombocytopenia, I'm still kind of under the doubt that these patients are still susceptible to infection, because anytime you're in a hospital type setting, whether you have cancer, any of these conditions, I mean, if you just look at pneumonia, being in the hospital for more than 2 days with a lung condition makes you susceptible to developing, hospital-acquired pneumonia. So I would argue, even if, these patients weren't necessarily coming in because of like chemotherapy and stuff, they're still susceptible to those specific kind of disorders. So that's kind of what the journal article was. Again, we were focusing on, cancer rehabilitation, a topic all of us will see if we decide to go into the field of physiatry. It's very common. There's, thousands of patients that unfortunately are diagnosed with cancer, and it's our job to, make them as successful as possible and to be able to carry out as much of their activities of daily living as possible. So with that, we'll kind of go ahead and get started with some of the discussion questions. Again, I apologize in advance. I was hoping to do this with a partner of mine, so there might be, for some of these answers, kind of short and not specifically to the point. But the very first question on the discussion was, what is the goal of rehab for patients with multiple myeloma? Again, as I already kind of alluded to in the talk, we are physiatrists. Our main goal and philosophy is to maximize function for a patient. So what does that mean specifically for a patient with multiple myeloma? Well, multiple myeloma is a type of cancer. So that means most likely the patient's going to be receiving chemotherapy or any other type of medication that puts the patient not only susceptible to infection, but also just destroys the bone marrow, destroys, pretty much muscle, makes them weak, makes them fatigued, and ultimately these patients are not wanting to do anything. So ultimately our goal as physiatrists is, one, to, monitor them to make sure their medical conditions are doing okay. Whether that's just the simple facts of, if they have hypertension, just monitoring that, or if they have a history of diabetes, making sure their blood sugar is under control. But on top of that, if they're having issues such as they're too weak to get out of bed, well, they're too weak to get out of bed, that means they're not going to be able to most likely use the restroom. So what does that do? That makes them more prone to infection. They could, develop a bladder infection. They could end up developing, an infection if they're not able to pass their stool. So even these little things we as individuals take for granted, because, most of us can just kind of get out of bed or, get out of our chairs right now for listening. We can just walk over to the restroom or go ahead and walk over and make ourselves dinner or something. For these patients, they're not able to do that. And our role is to work with the rest of the rehab team, PT, OT, et cetera, and direct them on how we want the patients to get back on their feet, specifically to the best of their ability. Our goal is not necessarily to cure disease. It's just, to do everything in our power to get the patient ultimately doing whatever they were doing before the condition even developed. As far as, the second discussion question, it's kind of the same answer as I just alluded to, which was what role does the physiologist play in the medical care of patients with multiple myeloma? I don't want to sound like a broken record. I would argue it's kind of the same answer I already just kind of gave with, for the first answer. So I'm not gonna kind of beat on the drum. I'm just gonna kind of move on. The next discussion question is kind of on what are some of the risk factors of multiple myeloma. I think this is a nice little kind of review, especially for those, first-year medical students, second-year medical students that, boards is, always on the back of your mind, and you always need to kind of know these things. But so I kind of got this from the National Cancer Institute. Specifically, I went on their website, the American Cancer Society, and I just happened to look for multiple myeloma just to see what they had to say about it. And so the main things they discuss are age, and I had already alluded to back at the beginning of the article that most people diagnosed with multiple myeloma are usually around the age of 65. So for you young medical students, first year, second years listening in, the magic number is kind of 65. So if you have that 65-year-old male that comes in just not feeling right, and they're having just kind of some vague symptoms with like weight loss, maybe, they're just not feeling good, feel kind of fatigued, kind of dizzy. That should be kind of automatically letting up in your head that should be on your differential. Another risk factor, as I said, again, was gender. Surprisingly, actually, race plays a factor. In fact, according to the American Cancer Society, African Americans are actually twice as likely to develop multiple myeloma over white Caucasian individual. According to the American Cancer Society, however, they don't know yet. So for you passionate listeners right now, maybe that's a research project or research study you might want to consider doing down the road. Another big risk factor is radiation. Obviously, we live in a society where, it's CT scans, X-rays for anything. If you go into the emergency room, you're going to get the full body scan. You're going to get this. You're going to get that. Well, according to the American Cancer Society, that actually makes you susceptible to developing multiple myeloma. And I think being simply intuitive, you can kind of put 2 and 2 together. If you're sending that radiation straight through the bone marrow, you're going to kind of disrupt, the cell formation in the bone marrow, which ultimately could lead to mutations and ultimately cancer. So I think that's kind of common sense. So that's why it's very important, when we're deciding what type of things we want to order for our patient, not only should we determine what's the best course of action, but also what the amount of radiation exposure we'd actually be putting our patient at risk for. Another risk factor is family history. So according to the American Cancer Society, someone who has a sibling or parent with multiple myeloma is actually 4 times more likely to be exposed to it. So this is, again, a quick review, whenever you're interviewing a patient and you're going through the HBI and you get the family history and you've determined that, grandpa or dad or great-grandpa ended up having multiple myeloma, that should be in the back of your mind. If this, again, this older patient, 65-year-olds coming in with vague symptoms, that should be at the top of your differential. American Cancer Society states that they haven't seen anything as far as work exposure that might put someone susceptible to multiple myeloma. However, obesity has been shown to increase your risk. And this is I found that actually very interesting. I haven't yet to actually find an article and up to date. I'll have to do it myself, but at least on the American Cancer Society, they allude to it that obesity actually increases your risk. This is critical because obviously there's a huge epidemic in our country with the increase in obesity. I think it's, 1 in 4 individuals now are actually overweight. I think that, no one quote me on that specifically. I don't want to be, destroyed on that, but I want to say it's about now 1 in 4 individuals, which is very scary if you think about it, because not only does it put you at risk for, multiple myeloma, but, we could go on a tangent about all the other comorbidities that are actually linked with obesity, anything to do with the heart, anything to do with the kidneys, anything to do with the skin, et cetera, et cetera. I mean, the list goes on of what, being overweight can actually do to your body. And a final risk factor that the American Cancer Society actually talks about is obviously if you have any other type of plasma cell disease. So the most common one is MGUS, specifically stands for, monoclonal gammopathy of undetermined significance. And if you remember from your board studying, or, if you happen to remember it, MGUS is kind of the precursor to developing multiple myeloma. It doesn't mean specifically you're going to develop multiple myeloma, but it definitely puts you at risk. So, again, just knowing that any of these type of risk factors should make you kind of put the light bulb on, thinking that maybe I should start testing this patient for these issues. So that was actually a long answer for number 3. I apologize, but hopefully you guys learned something from that. The number 4 discussion question was the sample size adequate enough to fulfill the objectives of the study, and how might a bigger sample size have affected the study results? So let me actually pull up the article again, and I'll actually take you to the page actually where they discuss it. So right here, they went ahead and said that they used and I quote from the article, Pearson chi-square analysis were conducted on all the data categories in the dependent variable, quote, returned to the primary acute care service. Data sets were sufficiently large enough that the Fisher exact test was not needed. Therefore, pretty much they ran the Fisher test, and based off the amount of patients they had, the researchers argue that the sample size was large enough. To counter the question about how might a bigger sample size have affected the study result, I would argue, I don't know if the size would have made a difference. If anything, it would have kind of maybe confirmed the results even better. I would argue, and the researchers already alluded to this in their limitations of the study, is that it would have been nice to see other hospitals and cancer centers participate, so they could have gotten from a different sample pool, not just from the one place. If someone down the line wants to develop a future study, I think that would be a good thing to focus on, is not to just take it from one specific site, but from multiple areas. But needless to say, the National Cancer Center there's, I believe, and again, someone can quote me later, I think there's multiple National Cancer Institute centers throughout the country, where I would argue you could probably get statistics from all of those, and you could pool them together and make your own retrospective study from there. Or there's a lot of these, then they might be the same type of place. I might be wrong. There's all those different national cancer centers as well that patients go to, and I feel like you could get permission to possibly pool patients from all over from those areas as well. Again, I'm not a research buff, so I apologize if that information's incorrect. Someone can always post something on the Facebook or Twitter wall, or even shoot me an email after the end of this and say, no, to correct me on anything that I happen to say, because I'm just a fourth-year medical student. I'm trying my best to hopefully educate some of you guys, but I'm hoping this is a fun thing, fun opportunity, and hopefully the AOCPMR can continue doing this down the line, and we'll get more opportunities for other topics as well. But moving on to the next discussion question, which asks, how would the study be designed differently if functional independence measure scores and staging of multiple myeloma weren't known? So, as I already mentioned before, the FIM score is kind of one of our main tools as a physiatrist, and I'm not going to kind of go over it again, but for those that are joining in late, here's another picture of it. I mean, the researchers did say in the article that they weren't able to obtain the FIM scores of patients because there just was lack of information available. So obviously, I would argue a way to change it for future studies would be that as soon as when the patient, for whatever disorder, whether you're having, if you decide to research multiple myeloma or any other one, obtain the FIM score immediately when the patient's admitted to rehab. I don't think it's too difficult. I mean, it's part of any physical exam to kind of look at these different topics, you know, eating, grooming, bathing, dressing, toileting, bladder, bowel, transfers, movement, communication, social cognition. I mean, when you're just talking to the patient, you should be already kind of in your head developing, you know, what you would give this patient on a scale of 1 to 7. Obviously, you can bounce ideas off with the physical therapist that's working with the patient, the occupational therapist, and the speech pathologists that are working, or even the neuropsychologists or that are working with the patient as well. But, you know, as a physiatrist, you're the head team member of the group, and so it's important for you too to be involved with your patient care on that side of things as well. So just having kind of developing your own kind of way to test all of that in a quick, dirty manner. You know, if the patient's talking to you, okay, you're looking at communication. If you walk into the room and they're eating their breakfast, obviously they're not having issues as much with eating. When you're asking them about how they're using the restroom or how they're you know, getting up to have to dress themselves, obviously they can give you, hopefully for the most part, most of those answers, unless of course they're in a more disabled type of state, such as if they suffered a very high end level spinal cord injury or a very you know, bad traumatic brain injury where, you know, the speech might have been disrupted or the memory might have been disrupted or any of these other kind of conditions that you can't specifically control for sometimes, unfortunately. But I would argue for future studies, if they continue to do this, to get the FIM score immediately when the patient's admitted, and, you know, if they end up returning to the acute hospital setting as they were studying in this actual article, get the FIM score then as well, and just kind of compare what was the difference between when they were admitted and when they had to go back to the hospital. And then you could go ahead and get it again once they're discharged to actually see what might have been preventing them from being a successful candidate in rehab. So, you know, obviously if they're doing okay with bladder management when they get to rehab, but then they develop a urinary infection, one would suspect that it was because actually something happened with their ability to manage their bladder. Maybe something happened when they were in the rehab setting. But to see like that difference in the FIM score would be kind of interesting, just from, personally I think it would be interesting just to see, even though that might have only been like a week difference, a week in difference if the patient, say, was in rehab for a couple days and then had to go back. Even that few days, maybe there would be a significant change in their FIM score, possibly. I don't know. It would be interesting to see a lot of patients and see how much they would change from that side of things. As far as how staging could be incorporated, I'll first go ahead and load up. This is from Up to Date. So for those that are looking on the computer, or, you know, if you go back and listen to this podcast later, you should be able to see this. But I'm on Up to Date right now, and you can see what's called the Dury Salman staging system for multiple myeloma. That's D as in David, U-R-I-E hyphen Salman, S as in Stephen, A-L-M-O-N. And pretty much there's 3 stages. There's stage 1, stage 2, and stage 3. And as you can see on UpToDate, stage 3 is kind of separated into stage 3A and stage 3B based on the serum creatinine. And so, like the discussion question was asking, how could this be incorporated into, the study or future studies? Again, very similar to the FIM score. If there was a patient coming in, the Dury-Salmon staging system is based off lab values. So when they're admitted, the physician could either use the oncologist's actual consult report to see if they've actually given the patient a stage, or you could possibly stage them yourself. I would leave it to the oncologist personally. But for future determination, you could separate the 3 groups. I would argue to examine differences, we could a researcher could assign patients into one of these 3 stages and actually then see if there was a difference in return to the acute setting. A stage 3 versus a stage 1. Is a stage 1 more likely to be admitted versus a stage 3? Again, they weren't able to do that in this specific study, but for future studies, not even if it's based off multiple myeloma, but if it's any type of cancer, they're staging for every form of cancer, every type of cancer, and I think for any type of study, this is actually a critical piece that should be incorporated in any future study, because a stage 1 patient versus a stage 3 could have significant differences. As far as number 6, what comorbidity measures in a patient with multiple myeloma could have been included in this analysis? I already kind of alluded to some of the comorbidities that we just kind of look for in the hospital setting. Specifically for multiple myeloma, I guess the comorbidities that would be interesting that I guess we could look at, do they have a previous history of some sort of blood disorder, whether it's a form of anemia, any type of leukemia, lymphoma, any of the other hematological types of cancer. I think that would be an interesting one. A huge factor in our society is, blood pressure. Any type of heart condition, I think, is an important one that would be interesting to look at. And any type of kidney disorder too. I think if looking at a patient, I think a really interesting one would be chronic kidney disease, depending on what stage the patient's in, whether it's 1, 2, 3, or 4. I think that would be a very interesting one, a type of population to look at, because obviously multiple myeloma, one of the main organs that's affected is the kidney. Kidney function can tank rapidly with multiple myeloma. So if they looked at a patient population and looked at the 4, different stages, stage 1, 2, 3, 4, and obviously a control group that has no chronic kidney disease but happens to have multiple myeloma, that would be, I think, an interesting comorbidity to look at. But if anyone has any suggestions, feel free down the line to shoot me an email or post something down the line, or even if anyone looking to do a research project, there's an idea for one down the line that you might be able to do. As far as the next question on the discussion is number 7, it would ask, what would be the possible explanation for higher mortality in patients who transferred back to the primary acute care service for unplanned treatment? So, as I mentioned before, the study suggested that the 2 main factors associated with return to primary acute service were male gender and thrombocytopenia. Generally, thrombocytopenia in multiple myeloma patients is usually probably a result of being exposed to chemotherapy as a form of treatment. And as I already alluded to back at the beginning of the talk, how chemotherapy works. It kind of wipes out the entire system and makes the patient immunocompromised. And so as a result, you know, the blood marrow formation is completely destroyed. It makes you more susceptible to infection and anything else that us whose bodies are not immunocompromised, little scratch here, little scratch there, not a big deal, but for a patient that's, you know, on forms of chemotherapy, those little types of things can actually lead to serious consequences. But what was interesting was that they didn't use that as chemotherapy was actually an exclusion factor in this study. So I'm actually not sure what might have been a possible explanation for the higher mortality result in the patients who transferred back, because they found for patients that transferred back to the inpatient primary care acute service, and I quote, those that returned, their mortality rate was, median survival rate was 180 days versus 550 days. That's pretty large. It's pretty substantial if you think about it. 180 versus 550. That's pretty large. So that's why it's critical that when these patients come to see us for rehab, that we do everything in our ability to make sure that these patients do not return back to the hospital setting. We want to make sure all their medical conditions are being well controlled or stable, and there's no chance that these patients can get sick. However, the question was asking what might have caused it. The only thing I can think of, and I would argue, is, you know, anytime you're in a hospital setting, you have the chance of being exposed to any type of infection. And that doesn't even mean if you're on chemotherapy. I mean, if you happen to be admitted for something else, pancreatitis, diverticulitis, diverticulosis, et cetera, the list goes on, pneumonia, any of those times when you're in the hospital setting, you're already being exposed to all these other pathogens and weird things floating around in the hospital bed. So I would kind of argue, because of that, these patients who already have cancer, whether they're on chemotherapy or not, would already, you know, be exposed to these things, which would increase their chance of, you know, dying versus someone that would be in just the rehab setting. But again, I don't know specifically what could have caused the higher mortality rate, so I don't have a definitive answer for that discussion question. Based off, the final discussion question was, how could the inpatient rehabilitation therapy be modified based on the patient's subjective history and findings documented in this study? Again, I don't really have a specific answer I don't really have a definitive answer for that specific discussion question. I'll kind of leave it to you guys for your own kind of self-discovery and everything. But I actually just got a message from one of the residents that was actually listening in, and he actually had a huge statement. He actually had a huge issue with the study, was the fact that, and I quote, the CMM exempt from the 60% rule. There are only 10 locations in the U.S. for cancer that have this status. So what he was saying is that FIM scoring starts once the patient lands on the unit, and even prelim scores can occur within 24 hours of admission, and they're actually finalized within 72 hours. So he argues that, therefore, the only way FIM scores can't be obtained is if the patient is bounced off within 3 days. In short version, what the resident that sent me a message is saying, and I apologize for saying the wrong thing, is that FIM scores aren't finalized until within 72 hours of admission. So what he's pretty much suggesting is that if they had to go back to the hospital setting before that, within a day or two, there's no way to obtain an FIM score. So I apologize previously that I said, well, it would be easy, just get the FIM score within, you know, the first 24 hours. In fact, that actually doesn't happen. It's actually within the first 72 hours. So thank you, Adam, for correcting me on that one. I appreciate it. That's pretty much all I have for tonight's episode. I appreciate for you guys that attended and are listening actually live. Again, to review, for any members down the line as an AOCPMR member, again, you have access to every journal club that's been hosted since now till be forever. So if you're looking on the screen right now, you know, last month's article was on PRP injections, and the one for December was about, you know, trunk impairment during wheelchair rugby, and the list goes on. And you guys have full access to every single one of those. I'll just go ahead and click on another one just to show you. Pretty much when you click on one of these, it gives you the article title, the author, a quick discussion of what the article was about, and then the discussion points. So if we go back to this month's journal article, again, as you can see, it gives you the title, the author, a quick description of kind of what the article was about, and then the 8 discussion points that I pretty much was just talking about. So whether you decide that you have a journal club, if you're a resident and you want to use these discussion points for yourself, or, you know, if you're at one of the osteopathic medical schools and you guys host your own journal club, you know, these are a quick and easy way to get the, you know, ideas flowing versus just having someone present an article and then have someone have no idea what it might have been about. This gives people the opportunity to kind of get a quick rundown and be like, okay, so-and-so is going to talk about this article. I have a kind of gist of what it's about, and, you know, if I'm really interested, I can go back and download the article. And as you can see on the web page right here, every page has a link to both the article and the discussion questions. And with that, I appreciate those that were listening. Again, I apologize that we were having a little technical difficulties. I was hoping my partner would be able to help me with it. But again, if you guys have any comments, concerns, corrections like the resident already emailed me about, please feel free to send them to me. I'd be more than willing to get grilled, pimped, whatever you decide. But I hope you all have a wonderful night. Have a good President's Week, and good luck on those that are on rotation. Good luck to the first and second years that are studying for boards, and for the residents, keep up the good work. You guys will become awesome physiatrists. Until next time, take care, everybody. Have a good night. Bye-bye.
All inpatient rehab locations are required to fulfill a CMM, which is the Medicare, Medicaid 60% rule, in which case there are 18, I want to say it's 18 diagnoses that are considered within the CMM or guidelines for inpatient rehab. Most of those for cancer do not fit. Cancer itself is not a diagnosis that's included. Included diagnosis would be your stroke, your brain injury, spinal cord injury, burn, even your orthopedic injuries such as like a knee or hip replacement are requirements being usually, I believe it's over 80, and then there's a BMI requirement to allow it to be an inpatient unit. Most cancer patients, not all, but a lot of them are admitted under the debility kind of criteria, which actually doesn't fit the 60% rule. So when you look at this in a translation to a regular inpatient unit, being anywhere, it would be it's difficult to bring in a cancer patient in the first place because they don't fit that requirement. And if they don't fit the requirement, the unit itself is at risk of losing all payment for every patient in the unit during that time frame. Hence why it's such a big thing. The National Cancer Institute, there's give or take 2 to 4 cancer institutes per state. And out of all those cancer institutes, there's only 10 that are in this exempt status, meaning they can admit anyone for anything, for any reason, into an inpatient unit, which is a pretty marvelous thing. It's a nice way to get good care for these people who really need it. And most of these will then be kind of built into the hospital. So they'll be not a standalone feature, which would make this patient treatment group very difficult to kind of care for. But there are some other things just kind of playing out that in the nature of private practice PM&R or community-based rehab without a residency-based program, that's very different than what you see in kind of the academic setting. This includes both a consult model where rehab is not a primary caregiver of the patient, but they're only used as a consult, and then the requirement within rehab that they only need to be seen 3 times a week in community or private practice space outside your academic centers. Now, most physiatrists will actually see someone more frequently based on the acuity level they require, in which case this would be maybe one of those, but it's one of the things we don't know. Also, we don't know how often your oncology team was actually working with them and being involved in their care. So if you take this information from this study alone and try to translate it into general practice or in your general units that are outside these 10 that are across the nation, the information they give you is very difficult to bring because you're going to have a hard time just bringing in your cancer patient. If they're even ongoing treatment with chemotherapy, the repayment for a patient being brought into rehab is different than your acute care stay, where in acute care you're kind of given a pay-by-day kind of idea, versus a lot of your Medicaid, Medicare, when they're admitted into rehab, you're given a lump sum of money in the beginning. And then based on their Fim scores and their admitting diagnosis, that sum gets changed by national kind of expectations of Fim efficiency, discharge, and discharge location and goals of care. So as you kind of go forward, if you're doing high-level chemo treatments, which usually are multiple agents, very expensive things, that comes out of that some pot of money, which is why a lot of general units have a lot of difficulty admitting your debilitated, ongoing chemo treatment-based patients because that gets brought out of that sum. Now, if they have a high percentage of patients in volume, they can absorb that. But just from a financial aspect, it's difficult. Now, many units will try to do what's best for their patients. They might do kind of a workaround with the oncology team where they kind of play hot potato with the patient, which is kind of a bad analogy, but they'll do the rehab kind of transition of care for maybe a 3-day stay, which is considered a complete discharge, allowing you to do a readmission under a new kind of diagnosis setting and state of medical need of the patient, and then rebring them in that way. But that plays a lot with insurance and kind of teaming the line a little bit, but it is one of the methods that it does get used. So that's one of the kind of things that is kind of a huge issue with the study, kind of looking at just the logistics and translation of what they're finding. Outside of that, there are many studies based on discharge to acute, looking at different things, like you already said, just the idea of the Fim score on admission and even on discharge and how that plays a role. But there are many other things that kind of significantly affect kind of regular general brain, stroke, spine-based admissions and their discharge rate, which were not included within their study. And the idea of goals of care when they have life expectancy to half a year to essentially just shy of 2 years, that's a kind of different thing. And then I think what also would have been very significant to be helpful is looking at the idea of what infections they actually treat or were being found with, since that was the primary thing of reasons for discharge. On the inpatient units I've been on, it's not abnormal to have 1 or 2 patients septic, and you manage it as long as you don't have a need for a cardiac monitor or pressure support.
Interesting. I didn't know
you
that.
deal with it.
Interesting.
So at this time, for these cancer patients, it is a little bit harder So it becomes a question of what was the turning point that made them do a transition. Even the thrombocytopenia that they have, it's only down to 80K. It's as long as it's stable and not active bleeding. Once again, it's not at normal. We transfuse, we go forward as long as we can have the support from the oncology team to say we can still keep on going. And I've had people, probably the scariest one I've had is someone with platelets down to 10. So it is feasible to continue to treat. I understand that with the cancer patients, you do have kind of a difference, and even their white blood cell count is above where you get like a neutropenic or a kind of dysplastic reaction. So their discharge rate, they mentioned some vague ideas. I would like to see some more details to really hone in on what they're going for. And their discharged people in general with the higher bench joist protein that he kind of already put, that they're a higher stage level of their myeloma. So your goals of care already would be a little bit different than if you were having someone that you knew was maybe going to have 3 or 4 years life expectancy versus a half a year. And what you're attempting to do with family and education and kind of going from there, such as caregiver burden, changing with transfers, bowel management, bladder management. The reason that they have an indwelling Foley versus transitioning into a suprapubic, which would be a safer if they were able to be tolerant to that procedure versus even intermittent catheterization. So there's quite a few little things of this study that leave you open to some questions, but the fact that they went through and they had 143 people that they had in rehab with the same diagnosis is marvelous. But I feel like they missed some key points to really hone this out so we could use it in other rehab units outside of an exempt unit.
Interesting things you were saying right there. Like I said, I didn't know about the 72 hours that you were alluding to, and then all those certain exclusion factors that only those 10 centers in the U.S. kind of can take these type of patients. So I agree with you now that that definitely would limit the type of patients they could actually examine, and also limit specifically what they could actually study as far as patient population in that situation.
Right. And just to kind of clarify what I mean by that, so Fim scoring gets done, I'm not sure, and you may be aware, nursing, PT, OT, speech, all do Fim scoring. That occurs right away once they get to the unit. So actually within 24 hours, they have admission scores. So you were right about that. What they do, they talk with insurance, is what they do is they look at that first, what's called the evaluation period, which is usually the first 24, 72 hours of a patient's day, where they're put through like the ringer through PT to see what they can do or can't do in which each of the disciplines. And that's where they try to show the lowest functional level where they were at to do that for your admission Fim, and you can begin to see progress already. So those should be available. As for the ability for other units to admit these, any unit can admit someone with multiple myeloma if they have functional need. It's for the best of the patient. What becomes the issue is if you have, let's say, a 10-bed unit, 60%, so 6 of those beds need to be a diagnosis that fits within the 60% rule. If they have multiple myeloma and the cord compression, they would be put under a spinal cord diagnosis, and they don't count. But there's only room for 4 beds. Now, these are 4 beds excluding anything from a private insurer. So if there's maybe 2 beds or 3 beds that are private, that now means there's only 7 beds that you'd look at, and those 7 beds have to have a 60% compliance with the Medicare percentage rules. So that would only leave you 1 or 2 people that you could bring in that are other diagnoses. And those usually are your transplants, your deconditioning, your myopathies of different types. So they can be brought in. It's just you got to make sure you balance it. And to get the high volume to make it really feasible like they did in this study, and they have this unit that can take them, is a really amazing thing just in itself, that they don't have to abide by those rules. And then even if you can bring them in, most units get caught in the fact that they got to play, when do you admit, instead of saying this person needs it, it's do we admit after what round of chemotherapy, when they're done with chemotherapy? Do we do a pre-rehab where we do everything and then they go through their chemo treatments, like an intensive course, short cycle, and then we admit them between their cycles of chemo and then discharge them back for the chemo treatments? So you can bring them in. It's just very difficult to keep them there and make it so you can see many of them. If that makes sense.
It does. It's definitely something I'm hoping to learn next year with, assuming I match next month and everything. I'm hoping.
Oh, you will. Just a matter of where.
Well, thanks, Adam, for the input and stuff. It's up to you. I did a separate recording with your addendum to this. It's up to you if you want it posted as well. I'll leave it to you.
If you think it's helpful, if you learned something for it, I would say go for it.
I did, because like I said, I didn't know about the 60% rule and everything. I'm sure there's hopefully other listeners that don't know about it too, and all that stuff that probably you've learned more through residency than, and I'm hoping I'll learn through residency as well and everything. Yeah. Cool. And
you will also learn that the physician actually has a huge impact on their Fim score. Purely example, like your different categories for, say, safety and problem solving. If they're on restraints, I think they can't get more than a Fim score of 1. Doesn't matter if they're completely oriented and alert and interactive. If you have them on any type of restraints, they automatically get a 1.
Gotcha.
Versus if you give someone bowel meds, that means the highest that they can get is a Fim of 6, if I remember right. But if you make those PRNs, they can suddenly make it a 7.
Oh, okay.
If they come in and you put them on fluids, same idea. If they can't manage the fluids themselves, they get Fim lower.
Alrighty. Cool, so, man.
Yeah. All right.
Well, thanks for the input.
Yeah.
Hopefully you enjoyed at least my piece of it. I know it was probably a lot of ums and vocal fillers, but hopefully you got something away from it. Hopefully those that were listening.
Yeah.
Like I said, we're trying to get these posted so that other people that can't attend can still listen and everything. It's still kind of like a work in progress, but
no, the article is good. It presents a lot of unique ideas, and the fact that people are looking at it and they have the volume of multiple myeloma actually in rehab, it's a pretty great thing just to see. Oncology rehab, the cancer rehab side, is everything is kind of new and exploring and developing. So the fact that people are doing stuff and getting results and having ways to bring them into the units without getting their hands tied, that in itself is amazing to see. The fact that you guys are looking at it earlier, where this is kind of a growing side of rehab, is also going to set people up for a great spot when they're out on rotations and talking with people.
All righty, man. Well, I appreciate the input. Keep up the good work, and I'll catch you all later. Have a good night.
You as well. Talk to you later.